I'd like to extend my greetings to all of you who are attending the Adherence 2020 virtual conference. My name is Dr. Jose Zuniga, President of the International Association of Providers of AIDS Care, or IAPAC, and a past co-chair of this annual series of conferences. Over the past 15 years, we've convened in Dallas, Jersey City, Miami, and now virtually due to our new normal in relation to COVID-19. In that regard, I ask that we observe a moment of silence and memory of the 1,191,774 deaths that we have experienced as a result of the COVID-19 pandemic. Thank you. I also wish to recognize all of the health workers and lay providers who have valiantly labored at the front lines of the COVID-19 pandemic, as well as those who have doggedly worked to preserve a continuity of HIV services. Among them, many of you joining us today. Now, I'm very proud of moderating this 15th anniversary panel that aims to glance back as we continue moving forward to enhance adherence to HIV prevention and antiretroviral therapy within the context of optimized prevention and treatment continuum. I could speak for hours about the progress we've spurred through this annual series of conferences, not to mention the networking that we have facilitated, creating a network of colleagues and friends. But to maximize our time, I will introduce our distinguished panelists instead. Joining me for what I know will be a lively discussion are Dr. Reve Amico, Associate Professor at the University of Michigan's Department of Health, Behavior, and Health Education, Dr. John Nashega, Associate Professor in Infectious Diseases, Microbiology, as well as Epidemiology at Pittsburgh University's Graduate School of Public Health, Erica Castellanos, Director of Programs at GATE, which works internationally to achieve transgender, gender diverse, and intersex equality, and Midnight Punkasaktuana, Executive Director at the Asia Pacific Coalition on Male Sexual Health, or APCAM. So welcome to all of you. I have a series of questions to ask you in relation to not just your experience with the Adherence Conference, but also questions about where we're heading, particularly given the COVID-19 pandemic and the need to continue HIV services in a way that will allow folks to adhere to either their antiretroviral regimens or to pre-exposure prophylaxis or PrEP. So my first question to you is to you, Reve. You co-chaired several adherence conferences and presented quite a bit of your work at this annual series of conferences throughout the years. What rises to the top as far as approaches, innovations, or strategies that were featured at the conference over the years? And as you think about these approaches, innovations, or strategies, which ones within the behavioral science space have most moved the needle as far as prevention and treatment adherence?
Thank you. Thank you so much. And thanks for the opportunity to be with you all on this panel. Not an easy question to summarize briefly, but I do want to share a little bit about what I've really seen as changes, having been involved for so many consecutive years in the adherence conferences. I think my first conference that I came to was still in Jersey City, I want to say around 2007, 2008. And at that time, our conversations really focused pretty exclusively on adherence. And when we talk about adherence, really execution, so number of pills taken per prescribed. And recall at that time too, the regimens were fairly demanding, you know, up to 15 different medications or pills that one might be taking. And a real shift that you could see happening right around that time, and it was great to be a part of it, was moving from this very medical model, you know, kind of correlates dominated discussion around adherence to thinking about things much more, I want to say in a much more nuanced way. So becoming much more person-focused, thinking much more about structural factors, thinking much more about what it is to actually live the experience rather than kind of bean counting or quantifying it with numbers, so to say. So I feel as though the content of this conference has very much, it's not just mirroring kind of the innovative thinking. I think in many cases it tipped the needle on the innovative thinking because it brought together people of diverse backgrounds in a very open setting, small setting where people could have conversations together and allowed for those intersections or those boundary spanning conversations. Jerry Friedland gave a presentation at the first conference that I was at, and there was something that struck me in his talk where he kind of paused a moment and said that adherence is clearly at the intersection between behavior and biology. And that gave rise to, from then forward, an understanding of adherence as being biobehavioral. And we've even pushed it further from that point. And I know people listening now probably think that, oh my gosh, that's just a gimme, but it wasn't at the time. And I feel like that really pushed our thinking. Models that came up around that. So again, thinking about, we talked about the information motivation behavioral skills model at the conference, presented it there, applications of cognitive behavioral models, Anderson's behavioral model, social ecological models. So really pushing from thinking about this discrete pill to mouth behavior to thinking about a human being, and that human being operating within larger structures. And I think that is a very incredible advance that came about. In part, I think, with this conference. I think structural thinking is now very common. When I think of innovations, again, just around the very people that are at the table, one of the things I really enjoyed also and thought was innovative at the time was bringing in voices from the community, and Bob Remian did a lot of work in that area, but making people part of the conference, part of the discussion, part of the innovation, in terms of getting perspectives from people who are living the experience. And I think that was incredible and spurred a lot of innovative thinking. Couple of things that stand out, though, just to narrow it down, is talking about, I mean, if you think about it, during the course of this conference, many innovations around the world, just in terms of the years that we've seen. So, task, start early, prep, again, treatment as prevention, U equals U. So really memorable events happening in the world around us that I think got good coverage at the conference itself. One of the things I really do remember, obviously, is Ed Gardner with the Cascade of Care being a very memorable moment, really shifting our thinking even more. And then Richard Lester's talk on WellTel. That was when they announced the results of their WellTel project and launched an era of looking at things using texting, using phones, using social support. Also Jessica Haberer and looking at EDM and looking at how can we use a measurement that actually keeps you connected with people over time. And that's really led to an explosion as well as a recognition of qualitative methods, mixed methods, and again, interventions kind of prioritizing health and well-being, so being very much person-facing. So I think by way of that, one of the other pieces, not so much a moment, but just something that I'm thrilled to see, is just how prominent context and context discussions are. We've shifted the conversation of the conference to really include engagement in care more broadly. And I think that's been great and invites a whole wealth of conversations around many different areas of inquiry, and then also areas of support that might be able to be provided. So again, there's many that I could reflect on. I'm going to stop there because I probably could go on for about an hour, but to say that I think it's been an incredible privilege, and we've seen a lot of pivot points. But part of that, I think, is because of an open discourse, an ability to talk about unique findings that may or may not be the same between studies and between groups, but it allows us to have a conversation and to be productive and to innovate.
Thank you, Hervé. I mean, I concur with you on everything you said, but most importantly on our ability through the last 15 years to bring together the different fields. And I recall when this conference first started, as you noted, it was very medically oriented, and bringing in behavioral scientists really was like a breath of fresh air. But it also forced us to rethink some of the ways in which we were advancing our work, and think through the behavioral components of facilitating adherence to at first treatment, and then of course as we added prevention, that became prominent. And then bringing in community, which we should have done from the very beginning. And we tried hard at the outset, but I think over the course of the years, we've had remarkable community folks joining us, including, of course, Erica and Midnight, who are on this panel. I'm going to turn now to Jean. So, you know, Jean, you're too a past co-chair of the Adherence Conference. You're a prolific author and a speaker on the topic of adherence. And I think in many respects, you've helped chronicle the evolution in the biomedical aspects of antiretroviral therapy and PrEP adherence through your work. I wonder if you might consider or listing some of the lingering challenges in relation to enhancing adherence to antiretroviral therapy and PrEP. And moreover, how do we do that within the context of COVID-19, which exacerbates many of the challenges that we were already facing?
Yeah, thank you, Jose. So you touch really a very key point as we really in this together. So COVID has exemplified really all the major barrier we used to know for adherence, and from physical, emotional, social well-being of our patients have been threatened. And COVID just added to HIV morbidity, but also as HIV people are aging, non-communicable disease, cardiovascular disease, and kidney disease, liver disease, just added to those non-communicable comorbidity. And I can even, add STI, co-infection, malnutrition, and all that in the COVID era. It just, we've been seeing more issue about loneliness, depression, physical abuse, and food insecurity. And that is really impacted not only susceptibility to, COVID. As we know, comorbidity are the key major risk factor, but also, the possibility of getting tested or taking your treatment, collecting your medicine, but also accessing to PrEP. And all those issues, I think, have been exacerbated with COVID. But I have to say, this is really a time for us to think out of the box. And we have actually evidence-based, intervention for adherence and to keep maintaining virological suppression, so we can keep the third 90 of UNAIDS target still on optimal. And this is a really time to try to capitalize on all what we already learned in terms of what works in differentiated service delivery model. So bringing back a redesigned health system delivery model in COVID era by bringing back, antiretroviral delivery services from clinic close to patient, its home. You recall a couple of years ago, we did the meta-analysis looking at whether there is a difference for patients who are stable, HIV patients stable, clinic versus home-based pharmacy refill. And we found that it was non-inferior in terms of virological suppression and mortality. And I think this is an exciting time, and speaking mostly from my own experience in a resource-limited setting in South Africa and in Sub-Saharan Africa. So we are driving all those community-based model of HIV treatment services, like a place like Namibia, where we experience a lot of increased community-based heart model with good retention of viral suppression, and also innovative evidence-based intervention like, multi-script 6 months, been shown to be non-inferior to 2 months. So those are interventions we try to capitalize during COVID era. to try to, people during lockdown to space their refill to those multi-month, refill medicine. Actually, I have one of my postdoc students just finished some time ago a randomized controlled trial showing that 3-month versus 6-month dispensing of antiretroviral for stable HIV patient is totally safe and feasible. But the innovation comes mostly also in Johannesburg. We also have people can refill their medicine for diabetes, blood pressure, using an ATM, kind of an ATM machine dispensing medicine. So you don't need to go to the clinic. And during COVID era, those are very convenient and located in township. So people don't have to travel distances to go to refill their medicine. And we presented at CROI last year also in South Africa in the health private sector program, patients can have their medicine courier to their home instead of they have to go out of their home. And I think using implementation science to try to scale up those evidence-based intervention is going to be key. Recently, Jane Simoni did dispatch through our network of Adherence email network, a study by Rani Barnabas from UW was a community-based antiretroviral versus community-based antiretroviral delivery model for HIV who are unstable and men. And it's been shown that those kind of community for key population hard to reach like men, it's a paper published in the Lancet, is quite effective and make a difference. So I think this is an exciting time to think out of the box under COVID era to try to move all the HIV treatment and prevention services to the community. It's a model that has been shown to be effective pre-COVID era, but we can maximize through implementation science during COVID. So I will stop there, but I think that kind of what we need to start to think of as we're moving forward.
Well, Jean, I'm excited that you're excited, because at the same time that we're all feeling this sense of loss, both collectively, given the experience we were having with severe COVID-19 outbreaks around the world, but also personally, as we're dealing with all the repercussions of COVID-19, from physical distancing to economic constraints, et cetera, we need to maintain our eye on the ball. And the fact is that we had very good forward momentum, good wind in our sails pre-COVID-19. Of course, everything was imperfect, but we were moving in a direction that I thought, looking at the bigger picture, that would allow us to come as close as we could to the 90-90-90 targets by the end of this year, as close as we could. Not quite there yet, but as close as we could. So I'm excited about your excitement, and I hope that other people share it, and that it infuses a sense of momentum that we need to keep going to make up for some lost time and to fast track and the response where it has been unfortunately derailed. I'm also thankful that you've raised the issue both of community delivery of services and community engagement and implementation of science. Of course, these are two new tracks at the Adherence conference this year, and Erika is co-chair of our community engagement. I think we've seen proof positive that delivering services at the closest proximity to patients is quite effective. And so to see that scaled up, even within the context of COVID-19 is excellent. So I'm going to turn now to Erika, because you have been among the most passionate community speakers we've ever had at the Adherence conference. You put into real world terms the barriers that are faced by transgender women in accessing quality HIV services, but also the need to engage with affected communities to translate science into practice. It was thus only natural for us to ask you to co-chair our new community engagement track, and I'm very excited about participating in some of those sessions over the next 2 days. But my question to you is really, what are your thoughts about how far we've come and how much further we need to go in order to realize GIPA and MIPA?
Thank you very much, Jose. It has been a real pleasure and an amazing learning experience to be co-chair of the new community engagement track, which is in itself a testament of GIPA. The conversations with various experts in a wide variety of thematics have been extremely rich. And if any of our viewers have not been able to see the sessions, I strongly encourage you to enjoy the community engagement track sessions in Adherence 2020. The HIV response is unique, and it has historically been steered by us, the community, from its beginning. We wouldn't have the treatment if it wasn't for us. We organize ourselves from networks and funding agents to address the epidemic. Our lives and the involvement through and in the response has evolved dramatically. At the beginning, we had to struggle with acceptance, and our goal was to provide our peers with comfort. In many parts of the world, the only thing we could do was ensure that our peers had a dignified death. With our efforts, demands, advocacy, and our blood, we changed the HIV response. With the availability of treatment, we migrated from acceptance to a survival mode. The fight to access the life-saving medication, the diagnostics and services we needed to stay alive. Those were very difficult, but indeed amazing moments of community strength. Through our continued advocacy, we have managed to move away from survival mode, and I believe we are now in the quality of life phase. In the same manner, the HIV response has evolved, and our lives with it. GIPA has also evolved and continues to evolve. The greater involvement of people with HIV/AIDS has always been a guiding principle of the movement for the past decades. GIPA is never achieved once and for all. It's not something we can tick and as if it is done, because it's a goal, it's a commitment that must be continually renewed. GIPA is a practice, it's not a project. It is similar to other accountabilities of health HIV organizing and service delivery. If we look at the history of GIPA over the past decades, we can clearly see its evolution. Since 1983 in the Denver Principles, which condemned the attempts to label us as victims and stated that we should be involved at all levels of decision making. Then came the Montreal Manifesto of 1989, which called for the active involvement of affected communities. Thus, it moved from involvement to active involvement. And so it continued to evolve when we reached the Paris Declaration in 1994. Then we called for a greater involvement of people with HIV at all levels, national, regional, and global, and support the creation of supportive political, legal, and social environments for people living with HIV. And this is the fundamentals of GIPA Declaration. And then in UNGAS 2001, we saw a resolution affirming the GIPA as expressed in the Paris Declaration. And so GIPA has continued evolving. It's not static. It continues to progress and develop according to the evolving needs of people living with HIV and the dynamics of the epidemic. How far do we need to go? Well, the answer is simple, all the way, and continue evolving. When we arrive at one goal, then we set another goal that is higher. The Adherence Conference has continuously given us a space for community. And with the new community track, we are elevating that engagement to a new level. We can't stop at having people living with HIV at the table. We need to achieve having people with HIV in leadership positions. Although it's unfortunate that GIPA is not a reality in all countries around the world, also, we don't all enjoy the same levels of involvement, but we continue towards GIPA from wherever position we are. And that has been the characteristics of us, the community, from the beginning of the epidemic, to strive for more to work on continued improvement and work together, be resilient, and improve our involvement in decision making. I think there's much more to do, but we also must recognize that we have come a long way, Jose.
Thank you very much, Erika. I mean, there's not much more I can add to that other than saying amen. We need to be in a place within our respective medical, behavioral science, other academic communities to not have to think about engaging community, but just doing it because it's the right thing to do. And you're right, there are different levels of engagement as we look across the globe. And in some instances, there's tremendous room for improvement. It's just good to have folks like you who are willing to lift the heavy burden and make sure that the message gets out there to the broader HIV response. That community should be leading it. So thank you very much. So Midnight, through your efforts at APCOM, your staff and you work with community groups and civil society organizations to build their capacity to better promote the rights of gender and sexual minorities. You have particularly close insights into the topics of stigma, both HIV-related and intersectional, which you helped us to address at past adherence conferences. I'd like to ask you, in your opinion, what are we missing as the secret ingredient or ingredients to eliminate stigma perpetrated against people living with and affected by HIV?
สวัสดีครับ Warm hello from Bangkok, Thailand. And I hope everyone is keeping safe and staying strong in this unpredictable time. My name is Midnight. I am from Thailand and I work as the Executive Director of APCOM, which is a regional key population network established in 2007. We work in Asia Pacific region to improve the health, rights, and well-being of people of diverse sexual orientation, gender identity and expressions, and sex characteristics. Thank you very much to IAPAC for the invitation to join Adherence 2020 conference. And I'm so excited to join this session with other panelists to give my perspectives on 15 years of innovation and going the extra mile. At APCOM, we have over a decade of working with the community over 30 countries in Asia Pacific region. And with so many decades that HIV has been with us, yet stigma and discrimination is still so prevalent. I don't think there is a secret ingredient or ingredients, but the gap demonstrates that we need more programs to tackle stigma and discrimination, including self-stigma as well. I also think there should be new information about HIV treatment and people living with HIV targeted at the younger audience and also general population to help change their perceptions. Stigma and discrimination is still rife in the healthcare settings, so there should be more opportunities where the providers get to meet the community outside healthcare settings to understand on a more personal level on how stigma and discrimination gets played out in healthcare settings. And I think this is where the community-based organizations can also support the facility-based providers as well. As more and more people can talk openly about HIV and people living with HIV can talk about their lives, this can really help normalize attitudes. And I hope that would also then change the way that people think about HIV and people living with HIV.
Thank you very much, Midnight. I concur with you that there is much to do still in relation to stigma and discrimination, including within healthcare settings where we have unfortunately documented it in many regions of the world, including North America. I'll turn to Reve now. And you know, Reve, much of your work has revolved around PrEP uptake. In fact, you presented a novel HIV prevention cascade at one of our adherence conferences, which even PEPFAR references today as they work to expand access to primary and secondary prevention interventions. Yet, as we look at PrEP scale up, it's at a slow pace and its use is uneven across key populations, including women. So what are the challenges and what more can we do to address them so that many more HIV negative individuals can benefit from PrEP, including as COVID-19 disrupts access?
Yeah, thank you, Jose. And just an additional amen to throw in there to the comments from the previous speakers. Thank you. I think that when you break down, I mean, it's like any tool, right? And this goes back to the implementation science side of things, right? So if you discover a tool, there's several steps that still need to happen before you can actually have wide scale benefit from that particular tool. So you have, you know, it needs to be available. You need to have awareness. There needs to be ease of access, as we just talked about. There needs to be uptake. There needs to be continuity. In the case of PrEP, there also needs to be some kind of system in place for safe stops and safe restarts. And I would argue a safe package should PrEP not be for you, and now you are engaged in a conversation about prevention. So all of those pieces, you know, happen within a larger context. They involve so many people at the table. There's policy, there's resources, there's money that needs to be put towards having access to PrEP, towards raising awareness. And then there's obviously decision making around community members and communities as a whole. So, you know, there's a lot of space there for what may have been able to go a little bit better. And if we focus on the issue with women, and we actually just had a panel talking about PrEP within cisgender women in the US. And, you know, in that group, you know, the cisgender women make up 19% of new HIV infections in the US, and yet they're 7% of the PrEP users. So there's this incredible discrepancy in terms of who is availing themselves of PrEP. But it makes a lot of sense. When you think about the way in which PrEP rolled out from 2012 really up until very recently, a lot of people were excluded from those conversations and from that marketing and from those efforts, down to providers doing their own exclusion kind of algorithms. So I think that when you think about the slow uptake, to me, it really makes sense given the context in which all of this rolled out. And so and I'll focus a little on women, you know, while there's certainly unique and shared kind of barriers and facilitators, as we've tried over the last few years, I think much more aggressively and heartily to include women in the conversation, there's also a need to shift our programs so that they're better met to where women go, and what services are considered valuable, and allowing people the opportunity to be part of not only the discovery science, but also the implementation science, figuring out, you know, locally really what are the biggest needs, how might services be able to be offered, and really centering or tailoring. We talk about differentiated care. This is more like differentiated service delivery. So I think all of those things are relatively important to think about. I know one of the things that always catches me off is when people say, gosh, why doesn't anyone want it? And it's not an individual thing. And if you think about the pattern with which women particularly were excluded from conversations, it's amazing anyone does want it. So I think that it's really making sure that we continue to keep things in context, because then that will help us to change that context and get people more involved in the conversation. As I've said, I think it's gotten a whole lot better, and we do see, what is it, a incredible fold increase, I believe, in uptake among women as women have become more part of the conversation in the US particularly. However, we also continue to remain being excluded. If you look at the Descovy studies, you know, we were not involved in that. There's research being presented at this conference that, you know, doing a lit review to see how open label PrEP adherence is. There's very few studies that actually had women as part of their samples. So we know that a lot is left to be learned, but part of the slow rollout has certainly been that in many ways, some groups were almost felt like afterthoughts in that rollout. And so now you have to change the conversation. You have to change people's ideas about what PrEP is and who it's for in order for it to seem like it's relevant for them. But I don't want to sound gloom and doom, because we have made tremendous progress, and there are a ton of different projects that are going on that will be coming out, you know, soon, in terms of how we might be able to work and engage effectively with cisgender women and transgendered individuals as well. I do want to, you know, say a little bit about internationally. I do feel as though PrEP is also gaining a better, there's more rollout of PrEP and uptake than there was previously, I think in part because what you're offering is different. There are less strings attached. And we talked about this in this conference in the past of randomized controlled trial drug adherence is not the same thing as open label PrEP. Would you like this? It works. Yes, please. PrEP. And so we are getting more and more data around that. And I think that that is a huge benefit when you're thinking about being able to offer PrEP, particularly if it can be in the context of other services, to people who are interested in it. I do want to take a quick note on COVID-19 though. All available data to date does seem to speak to increased burden among women for for COVID-19. Now we know that being a male is a risk factor for mortality, but being a female is a risk factor for job loss, economic instability, and many other deleterious outcomes that are coming with these mitigation strategies and kind of this new normal. Some data to date, I think women are like 1.8 times more likely to lose their job in the US in comparison to men. Unemployment for women rose 12.8%, 9.9% for men. 32% of the women in the workforce have a child under the age of 14 in their home. 30% under the age of 6. 21% of children in the US live with a household where there's a mother and no partner. And even if there is a partner present, women tend to provide 60% of the childcare in houses where there is a mother and a father. So when you think about COVID, you are more likely to lose your job, which is going to put you in economic instability. If you are working from home, you are way more likely to be spending multiple hours double tasking and managing family and children within the household. And there are far more, I think 5 times more mothers than fathers who have had to request reduction in hours, even if the job was available to them. So if you think about that in the US, and we know that that is replicating in other countries as well, and women are already burdened in terms of prioritizing self-care, that is a fairly tough scenario for most women to now carve out time to you know, enact prevention strategies, to go and get PrEP, to go and get tested. So when you think about, and I know Jean was talking about this in community services, the US, we envy a lot of other countries for their current infrastructures for community-based work, because there's a lot of places in our country where we don't have that. But really thinking aggressively about how can we get the tools that women need out to them affordably, given this context, given insurance and losing insurance, and given inability to kind of get to places. That is critically important, whether that's mail order or coming to the house or some central community area. That's somewhere that the US stands to learn quite a bit from other countries who have moved a lot further along that way. Thanks, that was a lot, I apologize.
No, thank you. And you know, it's so wonderful that you brought up the issue of gender inequality in relation to COVID-19. And of course, we've dealt with that too within the context of HIV and other diseases. So thank you for raising that. And as important, reiterating the importance of community engagement, particularly in countries such as the US that have professed an interest in ending their HIV epidemics. That cannot happen without communities at the table. And it cannot happen without community leadership. And so that's an important message that we're pushing, and I'm glad that you have spoken it here at this during this panel. I do want to have a quick follow-up question, though, in relation to the projects you were referring to, and I assume that one of them is the prospect of, or not the prospect, but long-term, long-acting PrEP. Do you feel different about the rollout of long-acting PrEP than what we experienced with Ilse?
Mm. So I do believe that there is more thinking around the inclusion of cisgender women in work going on with cabotegravir or long acting. The lament that I hear from many people, however, is that it often feels like a second thought. It's the second study, it's the sister project. And what that happens with that is you end up oftentimes, by design or simply for other reasons, but you have your results for your the non-cisgendered samples before you have results for your cisgendered samples. So it does put you in at times an awkward position of oh, do we have guidelines for this, but then we don't have guidelines for that. So while I do think that it is much better and a lot of time and attention and effort and advocacy has gone into making sure that women are represented, I think there is also the pause of it being sometimes feeling like coming in second.
Thank you so much. So, Jean, I'm going to turn back to you, and I think it's no surprise to any of us that the world was already off track to achieve the UNAIDS 90-90-90 targets by this year's deadline. The COVID-19 pandemic has thrown us further off track, though frankly we don't know by how much at this point. So HIV services disruption has been documented by WHO, UNAIDS, and IAPEC, and I'm wondering how far off track you think we are, and what recommendations you would propose to re-accelerate our HIV responses to get back on track for the 2030 deadline to achieve SDG 3.3.
Thank you, Jose. I think the first question is somewhat difficult to answer because we need to try to evaluate how far we out of track and try to assess that by region, by country, and it may be different depending on the region. But just talking about COVID, getting us a bit delay on our target, UNAIDS target. This is also an opportunity for me to comment on this kind of a paradox we are experiencing, how COVID is affecting differently Africa compared to the Europe or US. Everyone was, projecting that this is going to be a disaster for Africa, and paradoxically, Africa is the less affected continent. There have been some hypotheses what may be the reason. The younger pyramid age population, people mostly, living outdoor, maybe some genetic factor, maybe, despite all the cultural and socioeconomic challenges, we are at the bottom in terms of mortality and incidence of COVID. So there's still things we don't understand. That said, we are experiencing, South Africa, actually, my pit background is kind of misleading. I'm in Cape Town. And South Africa has been kind of at the epicenter of COVID. And and I think we can evaluate in the country where COVID hit the most. It will be good to work with people like Andrew Bull at UCT to try to evaluate, and other colleagues, Francois Venter and others, to try to evaluate how far it did impact, especially, for example, the FID90 virological suppression. So those data we can come up with. So that's then your second question, how to try to gain what we lost in terms of getting the momentum. And I think, again, I will go back to what I just comment at our first question, is to try to really to scale up and to find a way we can increase uptake on really intervention. We know they works, and I think we've been already working hard with a partner like UNAIDS, WHO, to try to, increase uptake of all the differentiated service delivery model, DSD, as Wafa used to say. And I think we need to see how to really speed up those uptake. But I will also, in our previous panel with Jen and Jessica, we were also discussing all day that one size does not fit all. We need to also think out of the box in the way that we can combine intervention. We are now in an era where we need to combine intervention, and not everyone going to need the same type of intervention. We're gonna to try to evaluate the intensity, depend where we are, which setting we are, and which population. And this come, bring me back to this important point also of the key population, especially from my experience here in South Africa. Key population hard to reach: the men, the adolescents, young women, especially in high-risk places like KwaZulu-Natal, in high-risk prevalence, and also commercial sex worker, MSM. So those key population, I think, are the priority for us once we try to re-emerge from COVID, really to try to, as we say, evaluate how far we've been out of track, but also try to speed up uptake of intervention by try to combine them. And again, it's somewhat, we're somewhat lucky that Africa has been less, spare a little bit COVID. When you see the disaster in India, in the Europe, and back home in the US. But maybe, as we can say, we may learn also from Africa, what is happening here in terms of just the behavioral aspect of COVID. Everyone here wearing masks is natural. South Africa, they comply with, and so obviously there's still some, we don't have much denial people about behavioral. So as the Rive was saying, we need to look at also what works here in this setting, and what can be applied elsewhere. Yeah. I think those kind of for consideration, I will try to, I try to approach here, but I'm interested to hear, especially Rive and my colleague Erica, for key population, some other ideas. Yeah.
Okay, so let's hear from Rive and Erica before I get to my next question. Erica, do you want to start?
She's muted.
Sorry, yes, I was muted. Yeah, I think, there's a lot of things to be done, and I think there's a lot of absence of data also, particularly around this time, and particularly this year, all the confusion that COVID has caused. When it comes to about how far we are from the 1990 targets, our community remains really very worried, because, when we're talking about, we were having a discussion at the one session for the community track, where we were discussing the term left behind and people hard to reach, which is often used even by civil society, donors, states, always saying, oh, those are key populations, are people hard to reach. And we concluded it's not hard to reach. You're just not finding us, you're not doing it right. Let us do the job. So, and that's the same thing if we want to reach the targets, we need to have the community involvement, community-led services. We have heard some good examples with migrants and sex workers in Europe, where health clinics are being completely led by the community, providing hormone replacement therapy for transgender people along with ARV services. And it has increased the access exponentially. And the same thing is happening in Latin America with mobile clinics, where the mobile clinics are out there at 2, 3 in the morning where the sex workers are located to provide testing, to provide treatment also, and follow up, including diagnostic tests. So I think there's a lot to be done, but I do think we should be very worried about the targets.
Hervé?
Yeah, I thank you so much. I agree very much with what was just shared. I go back to thinking about intentional and unintentional non-adherence. And when you think about, you know, the unintentional non-adherence, so here's someone who you know, that has access to art, when has access to art, is highly engaged with it and does their, you know, their best to be able to take it. And we need to break down every possible barrier that keeps someone from getting access, right? So that goes back to, I think, the programs that we're talking about here of be in community. You know, have a trusted resource that's actually giving you your medical care and giving you, you know, access to your medications. Get in community. Don't make it hard to get to medication. I mean, we have people lining up in queue at 5 a.m. in the morning, 4 a.m. They traveled all night to get there. I mean, those are to me what would be considered difficult but low-hanging fruit, as far as, you know, let's get these barriers that are possible to get out of the way, get them out of the way. Get people access so that the people who would like to be able to adhere have the opportunity to do so. I think the intentional non-adherence is more difficult, and I think that with greater attention to things like real robust social support, you know, helping people who feel alone and depressed and highly stigmatized, getting as best we can some of the structural barriers out of the way that keep people from being able to kind of prioritize that self-care, and of course trauma as well, and working on people's very basic needs for safety, and addressing IPV. So I see it almost as, you know, not something that should be done first, second, third, but certainly things that, like, to me, there are lower hanging fruit, and then there are really things like the differentiated care delivery that are going to be needed on top of that. And I did want to take the opportunity to say one more thing, because I do think that it's quite apropos that we often talk about capacity building. And oftentimes, you know, there's the resourced country that's the capacity builder. And I really, really want to encourage us to adopt capacity sharing, because all of the conversations that we've had just now really strike me as there is so much all of us need to learn from what works in everybody else's communities, as well as sharing what works in our own. So I do really appreciate you asking what might be helpful, Jean, but at the same time, I'm listening to you eagerly with what has worked in what you referenced as a resource constraint, because in many ways, it's very resource rich when you think about the level of community engagement that I think is really characteristic of places like KwaZulu-Natal, or like other places in South Africa. So capacity share.
Very good points from all of you. I mean, I share in your concern about the targets. I think we're going to start seeing some of the initial data around World AIDS Day, but that just will be a quick snapshot of the reality on the ground. But equally, I agree, there's so much we can learn from our colleagues and friends in other parts of the world, and too often we think we know better, and there's nothing that we could be taught about a new approach or a new way of framing our responses. And I agree with you, Hervé, that there is so much we can learn, including in the US, around what it means to not only have community at the table, that's easy in many respects, but how we create the space for the type of leadership engagement that's necessary, because that's the only way we're going to close the gaps. And as important, the only way that we're going to get to a place where we achieve as close to zero stigma and discrimination against people living with it infected by HIV/AIDS as possible. I don't know how we get to zero. I'm not sure we can get to zero, but we can get as close to it as possible. So Erika, I'd like to toss it back to you with a question around this issue of, we've made tremendous progress, great strides as you've spoken about earlier, but there's still so much that needs addressing. And so we've addressed, during the last 15 years of the series of Adherence Conference, many more issues than clinical and biobehavioral ones, as is clear from the discussion we've been having. We've tackled different discussions regarding gender identity, homophobia, transphobia, other phobias, sexism, racism, ageism, other isms. But as leading global HIV activists, what is your assessment of where we stand in late 2020 in relation to addressing and overcoming these significant barriers?
Thank you very much, Jose. And you know, I could give you a very short answer, which is that we're not even close from overcoming these barriers. Sometimes for me, it feels like we take one step forward and two steps backwards. You know, one country makes huge strides in removing legal barriers or other social barriers that are based and founded in human rights, and 2-3 countries, you know, completely go against human rights. And so it's very disheartening. But from a global perspective, we do need to recognize that we have advanced tremendously over the years. There has been huge advancement in general. If I think about 15 years ago, gender identity was not a huge discussion. It was not even in the radar of the mass majority of the world. Many organizations didn't have it as an objective even. We look at hate crimes, you know, in many parts of the world, they were not documented. More and more countries are documenting hate crimes. They're making sure that there's legal space also to follow them. And yes, you know, we see a lot of countries advancing around issues like gender identity laws for the transgender community that are based in autonomous gender recognition of the individual. But it's not the same in every corner of the world. We have very good examples like Malta, like Argentina, where legal gender recognition is something that is autonomous. I myself identify as a transgender person, and I don't need to go to a court or even go to a doctor that needs to examine me to determine my gender. We saw ICD-11 was a breakthrough in the pathologization of transgender identities. But in the vast majority of the world, trans people are still required to be diagnosed with a mental disorder. One still has to go to a hospital, see a psychiatrist for periods that go from 6 months to 2 years, until we can start getting gender-related health care for transgender people. And you know, very, very few countries have achieved legal gender recognition. And in some countries, trans people still have to undergo sterilization to access legal gender identity. Now, for me, that's something that is that I would consider even as medical torture, that one has to be coerced to undergo sterilization to be recognized legally by who we are. And we see many countries of the world, while some countries pass laws and policies that protect the rights of communities of transgender people, in others we continue being criminalized, and in so many countries of the world we continue being killed. The number of transgender people being killed in the world every year is alarming, and it's really sad. So we stand in a very difficult position that is not equal. When it comes to stigma, discrimination, and all these factors, not only for transgender community, but for other communities, for people of color, for Latin, and for other key populations, the world is not really a safe place for us to live. It is not a safe place to love. And it's more importantly, it's not a place that allows us to thrive as human beings. And on top of everything, now we are hit by COVID. And you know, COVID has come and it has put our world upside down. But and you know, sorry, because I'm concentrating a lot on the transgender community because I'm biased obviously about that. But you know, when COVID hit us, we saw countries like Hungary, who you know took that moment to just pass laws and just take steps backwards when it comes to legal gender recognition. We had countries in Latin America where they put lockdown measures and based on gender that is stated in your legal documents. So in some countries, for example, you couldn't go out to buy groceries, you couldn't go out to pick your medication because they only had 1 or 2 days a week that each gender can go out. But if your gender expression, how you portray yourself physically does not match the gender that your documents have, many trans people end up being in jail and harassed by the police because they couldn't simply get out of their house for simple things like going to the groceries. And that is highly problematic. So, you know, but yet our resiliency and our passion has kept us going even amongst this time. And it's what I take is the lessons learned from all these years, you know, with passion, with resiliency, but more importantly, with the community support we give each other. Change is possible. We have seen examples of where change is happening, and even in countries where the whole country does not have a law to recognize, for example, gender identity, states do. For example, in Mexico, where many states have already passed laws for legal gender recognition. So overall, in 2020, I remain hopeful because we have seen advancements, and what we have right now is each other as a community. And I think that's the best way to go forward. We have been able to mobilize in a very good way to help each other, to document, to, you know, once a country goes through the process, we share it with others to see how it can be adopted in other countries. So I think that's our greatest resource, ourselves as a community.
Thank you, Erika. I was going to go into the last question of the panel, but you actually raised a concept that I'd like to drill down on just a little bit with the three of you. And that is, you know, many of us live within vulnerable communities, and particularly in relation to COVID-19, the levels of social isolation, and I assume the levels of anxiety and depression, we'll know that clearer as we progress through the COVID-19 pandemic. These levels have increased as well. So I'd like to get your sense from your various perspectives about, you know, what does this increased social isolation and levels of anxiety and depression mean in relation to the optimized continua that we want and the adherence to HIV services, particularly prevention and treatment? And I guess we could start with Hervé.
So I think that's a huge question, and I think it's something that we don't quite know yet. And I also think that it probably hits people differently, particularly potentially by age. So I believe that, and we've pushed this a lot, that perhaps social distancing was really a poor choice of words. Because there are other ways to socially connect, and folks younger than me are way better than I am at socially connecting, not in person. So I do think that even though the physical isolation is quite real, that depending on, you know, who you are and your comfort level with electronics and you know, social media and that kind of things, that there have been ways in which people have remained socially engaged and connected. That being said, for those of us who do not really have either those skills or affordances to have those devices, you know, certainly the isolation has to have an impact, right? We know that depression period is associated with adherence in the best of times, right? So I can only imagine what this is going to look like overall. That said, I think that clinics and CBOs, ASOs that have been able to pivot to connecting with people by phone, by WhatsApp, by FaceTime, by video, you know, we can't say for sure, but I would hope to believe that people were able to remain socially connected. So again, I think it's going to be different depending on to what extent you can pivot, you know, and feel socially connected through these different mediums. And I think for some of us, that's going to be harder than others. I do want to say, though, people that kind of entered into COVID with feelings of depression, with experiences of trauma, with, you know, feelings that really do ameliorate when you're around positive and supportive people. I do fear that this is just a really, really difficult time. And if you're being asked to prioritize your self-care without really feeling good about yourself, that's a really precarious position to be in.
Thank you, Hervé. Jean?
Thank you, Jose. I'm going to speak mostly from LMIC Africa perspective, and I'm gonna, in interest of time, I'm gonna highlight only three aspects. The first one is food and security. So, as you know, most from Africa setting, many people live day by day, not check by check, but really day by day. So COVID just exacerbate inequality already, you know, poverty. So in setting like South Africa, there have been some, you know, government program to try to assist people and try to, and including some of our patients who are HIV infected. So that did help a little bit to try to secure some food, put on the table, and not think much about and just keep taking your medicine even if you're at home. But more worrisome is not all the provinces being able to access those government programs for assistance. And the other major impact was basically substance abuse, and on the top was alcohol. So one of intervention, nationwide intervention, and I have to applaud the South African government, was to ban all alcohol, you know, sale during the lockdown. They only gradually did authorize alcohol sale. But even banning alcohol sale, it did not, people been, you know, trafficking alcohol, I'm not sure how, but we saw, you know, report of alcohol abuse even during the lockdown, and obviously, and it did affect mostly in township. Some of our patients really, you know, interrupting taking their medicine over, you know, prolonged weekends, and you know, with breakthrough viremia. So we have to restart in terms of counseling and try to make a difference. Again, put them back on track. And the third point I think we experienced here was gender-based violence during this COVID era. So we saw huge, significant increase in gender-based violence. When you keep people at home, you know, it's not always easy, and the people to live together, and you know, coupled with tension, they always, you know, social workers were really overwhelmed, and also police with, you know, call for gender-based violence. And again, this is, it did affect our patients. Some of our patients been involved in those type of incidents. So you see the impact really of COVID is multifactorial. And we just starting to learn how it's been affecting. And I think, as I say again, we're going to need, it's a a multidisciplinary kind of approach to try to minimize the impact. And the sooner we get out of this challenging time, the better. But again, as we all know, this may take again until next year, because until we get to the new, to the normal kind of life we used to. But again, we are learning how to, to address this. As Rive say, it's doing by learning. Yeah, thank you.
Thank you, Jean. Erika?
Yeah, I think, what is important to realize, and speaking very, very particularly about the trans community, like we're a community that throughout our life, we suffer isolation, exclusion, and rejection. You are rejected by your family, by your friends, by society, by your country, because in many countries they have laws that don't accept you for who you are. So we have already been suffering of that isolation. It's so big. And then COVID comes, and then the little connection to another human being, which is with our community, that we have as a population, is taken away. So that human factor, which no tablet or no device can replace, is gone. So that was a big issue for depression, for the risk for suicide, for adherence to medication, for even following up with your treatment or and your doctor. And this is something that is equal in developing and the developed world. There is no difference. These factors affect the trans community everywhere. But what the community has been forced to do is to be innovative. Find ways on how we can connect those who need it the most. So for example, we have seen organizations where there's not a big space. They started making appointments so that the person can go there and at least be with another human being, taking the precautions, at least drink a coffee, but also other ways of connecting and using social media, using the internet, but not in a very business-like setting. Just listening together to music, or just connecting and let's work together, you in your computer and me, not even talking, but just seeing the presence, because many people from the community actually live alone. So that's, isolation is a big factor that affects the community.
Thank you very much. I mean, I think the resilience that I've certainly seen across communities has been quite heartening, and I certainly have learned lessons from it, particularly because I'm an old fogey, and for me the social media and all those devices that my son loves to use to avoid speaking with me work, but not for me. Anyway, I'd like to get to the last question of the panel discussion in the interest of time, and just to say that we're 2 months away from ending what's been an incredibly tumultuous 2020, to say the least. We've been humbled by the fact that a new virus has turned our world upside down, but also by the sad reality that our human covenant at times, as well as the concept of evidence-based public health, are apparently not as sacrosanct as we thought they were. So I'd like to end the panel by asking each of you individually, what is your wish for 2021? And we'll start with Hervé.
Well, I've thought about this, and it's going to be short and sweet. I have a sign outside my yard, and some of you may have seen it before, but it's basically, doesn't say it all, but it says a lot for me. And it turns out that the sign was actually made by a woman from Wisconsin, Kristen Garvey. I think she made it right after the election of 2016, mother of two. Made it with a Sharpie and a white poster board. And it has since really taken off. And for her, from what I understand, it was a reminder of how to live her life, and a reminder to her daughters for how to live their life. And the sign in nice bright colors essentially says, "We believe science is real, women's rights are human rights, Black Lives Matter, no person is illegal, love is love, diversity makes us stronger. And I look at that sign every day. And while it doesn't say it all, it says so much to me and hopefully to others in my country. So I guess my greatest wish is for more people to believe and to act on those beliefs every day.
My second amen of this panel. Jean?
Can you hear me?
Yes.
Yes. Also, I'll be very short. My second, my first wish is really to get a vaccine that can control this COVID as soon as possible. And then my second wish is basically related to the first one, is that I'm really puzzled to see how, as scientists, the science has been treated by, especially for my adoptive country, the United States. So I hope, the science going to gain back their voice and to lead public health. Thank you.
Thank you. Erika?
Thank you very much, Jose. And I'm also going to be very short. So for 2021, I wish for a year and future that is rooted in human rights, where decisions are taken based in science and human rights, that as a human species, we recognize our mistakes and learn from them. I wish that the expertise of communities is valued and respected. I wish for a vaccine for COVID. And I wish that the same interest and investment that donors and states have invested in COVID, I wish that same level, at least that same level, for HIV in the future. And finally, I wish that we strengthen the fragility of our health systems that have become so obvious with COVID.
Thank you so much. I echo all of your wishes and say, Midnight, turning to you, Bangkok is one of more than 300 fast-track cities worldwide. We're very proud of the work that has been done in Bangkok through a variety of means, particularly community engagement, not just in planning health services, but also in delivering them. We've presented on Bangkok's significant 90-90-90 targets progress over the years, including a 12 percentage point increase in the first 90, which people knowing their status from 79% to 91%, and a 31 percentage point increase in the second 90 from 57% to 70% over a 3-year period. So I'd like to ask you, although I've already biased the answer a bit, to what do you attribute such progress, and what can other fast-track cities learn from Bangkok? And finally, are you concerned that COVID-19 may set Bangkok off track as far as its HIV response?
Thank you for the question. Bangkok is indeed one of the handful of cities in Asia-Pacific region that is part of the Fast-Track Cities initiatives. Thailand has made many great strides in their HIV work. For example, in 2016, Thailand received validation from WHO for the elimination of mother-to-child transmissions of HIV, becoming the first country in Asia and Pacific region to do so. Thailand was also one of the first countries to provide pre-exposure prophylaxis to men who have sex with men, soon after the 2014 WHO Consolidated Guidelines on HIV prevention, diagnosis, treatment, and care for key populations was updated. The Thailand National Health Security Office has also been involved with supporting community-based services by reimbursing the costs for services provided.
Thank you, Midnight. I am grateful for APCOM's engagement with the Fast Track Cities work in Bangkok. Very clearly, you have your finger on the pulse of what is working and what is not working in Bangkok, and we're hopeful that we'll continue to see progress by addressing the challenges that you've addressed. That mine include the fact that I miss you all. I look forward to being around warriors who are willing to do whatever it takes to end the HIV epidemic, that, as our leaders have committed that we should do by 2030. I'm also, as you, hoping that we restore the common humanity and understand the interconnectedness of our lives, particularly given how much we've been reminded that we've lost that, at least for the time being, and that we once again restore confidence that should never have been lost in the first place, but restore confidence in science, public health, medicine, so that we do not have segments of our populations in whatever country that choose to ignore sound public health policy and in that way place other citizens at risk. So with that said, I'd like to thank each of you for your time on this panel. I think you represent the very best of the 15 years of our Adherence Conference. There's so many other people I would have invited, of course, but as is clear from our conversation, you represent the very best, and I'm very honored to have been able to moderate this session. I'm also hopeful that we can gather together in person next year for the 16th Adherence Conference, COVID permitting. So with that said, be safe, take care of one another, and hopefully we'll see you next year. Bye.
Thank
So
you.
much.
Bye.